Thank you for joining me. The title of this talk is Personalizing Pain Medicine, Making Nerve Blocks Last as Long as Patients Need Them. I have no financial disclosures. And I thought I would start this talk just looking at what the future of regional anesthesia and acute pain medicine may look like. This is an interesting figure that came from Knowable magazine. And I think this idea that we could personalize pain management for patients having surgical care is really something that we all are striving to achieve at some point in the future. We don't know if this is going to be years, decades, or centuries, but this idea that every patient is different and responds to the stress of surgery and the pain associated with surgery in a different way, it really should behoove us to try to find new ways to match how we apply pain management, prevention, and treatment to each individual patient. And so one day in the future, hopefully, we can do something similar to what you see in the figure, in which you can assess a patient's pain profile, sort patients into different types of pain subtypes. In this case, it mentions clinical trials, but you can imagine that this could involve clinical protocols for different types of patients and different types of surgeries, and then look at the various modalities that we can employ in terms of their pain management around a type of surgery, and really tailor a regimen that matches best for that particular patient. And then ideally treat each patient as they will most likely require in terms of their postoperative pain management and their recovery trajectory. So that way they all have a very personalized recovery profile when it comes to how we manage patients after operations. That is an ideal goal for the future. This is not where we are today. So for today's talk, I thought I'd discuss specifically what we have available in terms of peripheral nerve blockade, going over adjuvants for extending single injection nerve block techniques, looking at continuous peripheral nerve block techniques and an update of the evidence, as well as some practical considerations in deciding what makes sense for your patient that's in front of you today. So first, let's talk about adjuvants for extending single injection nerve block duration. So we know that placing a continuous peripheral nerve block catheter arguably is the most reliable way to extend the duration of nerve block effect. This involves either percutaneously placing a specialized catheter tube adjacent to a nerve or plexus, and then using that access in order to continuously administer local anesthetic solutions or intermittently inject local anesthetic solutions as more of an intermittent bolus type of technique. And although we know that continuous nerve block technology and techniques have been around for decades, we also know that many times we tend to justify the use of single injection for various reasons. And it may be that it may be time, it may be complexity, it may be lack of training. It also may be a question of whether or not we truly believe, or our colleagues in surgery truly believe, that a single injection nerve block is really fine. And so I think that there are various factors that go into the decision-making as to whether or not to use continuous catheter techniques. Now, that being said, single injection nerve block techniques have been available for a long time. And we do have adjuvants that allow us to extend the duration of action of plain local anesthetic. We know from pharmacology that currently the commonly available local anesthetic solutions are limited in duration, primarily based on binding to protein. And so the common local anesthetics used for long-acting single injection blocks tend to be ropivacaine and bupivacaine. Epinephrine is arguably the most common adjuvant used for extending nerve block duration. It is FDA approved in the United States for this particular purpose, and is prepackaged in some solutions, for example, bupivacaine with epinephrine as a compounded local anesthetic formulation, which can be used for regional anesthesia. We know that epinephrine works by decreasing vascular uptake through vasoconstriction. It may help in terms of decreasing or blunting the escalation of plasma concentration in terms of protection for local anesthetic systemic toxicity. We know that it primarily affects the duration for what we consider more lipophobic anesthetics, which would be mepivacaine and lidocaine, which are generally considered shorter duration. And it may not have profound effects on the duration of longer-acting local anesthetics like ropivacaine and bupivacaine, and we know that ropivacaine is also intrinsically vasoconstrictive. It has been used for years as an intravascular marker or test dose when regional anesthesia is performed, particularly neuraxial regional anesthesia. And this particular adjuvant has not been reliably shown to extend duration of action beyond a day. Clonidine, which is an alpha-2 agonist, is another adjuvant that has been used to prolong local anesthetic duration. It also tends to have more pronounced effects for lipophobic anesthetics, so bupivacaine and lidocaine, as mentioned previously for epinephrine. We know that brachial plexus and other types of peripheral nerve and plexus blocks have been shown to be prolonged when the adjuvant clonidine has been added. And the common dose would be half a microgram per kilogram added to local anesthetic solution. We know that higher doses of clonidine may have an increase in sedation as a systemic side effect. And we know from a systematic review, which included over 24 studies, that there is prolongation of lipophobic anesthetics such as bupivacaine for select types of blocks. So there is evidence to support the use of clonidine as an adjuvant, primarily for shorter acting local anesthetics. Similarly, we know that dexmedetomidine, which is another alpha-2 agonist, can be used to prolong the duration of action of local anesthetics. And this has been shown for both sensory block as well as motor block, with the exception of interscalene. And using a fixed dose of 50 micrograms may even speed the onset, although statistically significant. 3 minutes may not be considered clinically significant in many clinical scenarios. And we also know that when you compare the use of the dexmedetomidine to no dexmedetomidine, that there may be a risk of bradycardia if you use higher doses. So greater than 50 mics of dexmedetomidine added to solution may be associated with side effects. Opioids in general have not been shown to have beneficial effects when used as an adjuvant to local anesthetic solution, with rare exception. We do know that peripheral opioid receptors exist, but in terms of peripheral nerve block, most commonly used opioids that are administered intravenously have not shown benefit when added to local anesthetic solution. The exception is buprenorphine, and buprenorphine, of course, we know is not your typical opioid, and that is a partial agonist. When added to solution, it has been shown in randomized clinical trials to have to produce a longer duration of analgesia, even when used perineurally. However, the use of buprenorphine for this indication is not approved by the FDA. Dexamethasone has been somewhat controversial. We know that intravenous as well as perineural dexamethasone have been shown in studies to prolong the duration of action of both peripheral and also neuraxial blocks in regional anesthesia. In certain types of blocks, it has been shown prolongation, for example, in interscalene block, axillary blocks, supraclavicular blocks. It is used off-label when used in peripheral nerve blockade in the United States because it's not specifically approved for this indication by the Food and Drug Administration. And we do know that the controversy is primarily between the route of administration. And so in certain types of locations, so for example, foot and ankle surgery, as well as some other sites of nerve and plexus distribution, intravenous dexamethasone has been shown to be just as effective as perineural dexamethasone, which means that you can give it IV rather than mixing it with local anesthetic in your perineural solution, which is considered off-label. However, there are some studies primarily in the upper extremity, and these come from D-Trans group in Montreal, that have shown a benefit of perineural dexamethasone over intravenous dexamethasone. In previous studies, one of the limitations has been that there was no systemic control. So patients got perineural dexamethasone or no adjuvant at all. But in these studies performed by Tran and colleagues, they actually used an intravenous dexamethasone control and still showed some benefit of perineural administration over intravenous, at least for these particular locations, for axillary block and for infraclavicular block. So the truth is, we don't know, we can't say 100% that intravenous dexamethasone is the same as perineural dexamethasone in all locations. However, there are sufficient studies that show that there may be no great advantage of perineural over intravenous when you pool all of the data. So when I looked at all of these types of studies and tried to summarize them, this is an emoji chart, the summary that was inspired by Patrick Wong, who's at the University of Ottawa. I tried to figure out which adjuvants would reliably give you a block duration after single injection that would last more than 24 hours. And that would be the difference between waking up in the middle of the night or not waking up in the middle of the night for a patient having a first case surgery. And in general, most of these adjuvants do not extend the duration of block reliably more than 24 hours, with the exception perhaps of buprenorphine and dexamethasone, both of which in the United States are considered off-label use. And so, these may be considered, but I would also consider intravenous dexamethasone for cases in which that may be indicated for prolongation of action. If you look at combined adjuvants, and this is an area that has been studied primarily in animal studies. This is one that came from Rush University, Dr. Bupivacaine and colleagues. And you see here that combining local anesthetic, in this case, 0.25% bupivacaine, with multiple drugs, which included clonidine, buprenorphine, even use of dexamethasone. In these types of 4-drug combinations, the fourth being local anesthetic, in this case, clonidine alone actually accounted for most of the prolongation over the other adjuvants. And so it's still uncertain what the ideal adjuvant or combination of adjuvants would be for single injection nerve block. And it also goes without saying that, as I mentioned before, most of these adjuvants are considered off-label use by the Food and Drug Administration. So what about liposomal bupivacaine? And this particular type of local anesthetic has had much promise over many decades. And if you look at some of these studies, and you'll see here the study by Bogarts and colleagues actually goes back to 1993. And so we've known since 1993 or even earlier that this type of formulation, where bupivacaine is packed into liposomes, may lead to prolongation of block. And you see from this study, at least in rabbits, that the use of liposomal formulation extended the duration of block, at least in terms of motor block, and nociception for 96 hours. And I think a question that I have, especially when you have a duration of block that is so long and you cannot be titrated, is that duration always good? The reality in humans is that this duration has not been reliably demonstrated with the use of commercially available liposomal bupivacaine. And this has actually been fraught with a lot of controversy, and without going into a lot of details, the use of liposomal bupivacaine has a very limited indication in the United States by the Food and Drug Administration. It can be used for infiltration. It can also be used for interscaling brachial plexus block. When we look at some of the studies that have been published, and if you eliminate some of the sponsored studies by the drug manufacturer, many of the resulting endpoints have been negative when you compare liposomal bupivacaine to plain bupivacaine. The initial studies and the initial enthusiasm for this drug really came from placebo-controlled studies in which the control group received no local anesthetic at all. But when compared to local anesthetic, an active control, plain bupivacaine or even ropivacaine, as you can see here, the results are less convincing. And this meta-analysis published in Anesthesiology similarly confirmed this. When you look at peripheral nerve block analgesia in this systematic review and meta-analysis, the use of liposomal bupivacaine was not superior to plain bupivacaine. And you can see the forest plot showing the diamond crossing 0. And this has been controversial, of course, and the company that manufactures liposomal bupivacaine has sued the Society, American Society of Anesthesiologists, due to the publications in anesthesiology. This lawsuit has been dismissed, but is currently still an active case because the company has filed an appeal. There are some alternatives, and so this study was actually published very recently, this spring, and this came from the Hospital for Special Surgery. And in this particular study, they compared liposomal bupivacaine in interscalene brachial plexus blocks with the use of plain bupivacaine with the adjuvant paraneural dexamethasone. And you'll see here, they designed this as a non-inferiority study. And so showing that there was no demonstrable benefit between the use of liposomal bupivacaine because the results were non-inferior to the use of paraneural dexamethasone gives the opportunity to provide an alternative that may not require the more expensive formulation of liposomal bupivacaine. So let's talk more about continuous peripheral nerve blocks. Now, one of the challenges, I think, today, as we start to work towards more personalized pain medicine, is that we have to understand how long pain actually lasts after surgery. And you can see here from it's a very simplified schematic that certain surgeries may have longer durations of moderate to severe pain than other surgeries. And if we look across a population, now of course this is a pooled figure showing the results of 4 different randomized clinical trials. And so so I would take the interpretation with a grain of salt. But in general, you can see that amongst different types of surgeries, shoulder arthroscopy, knee arthroplasty, mastectomy, and hip arthroplasty, that the trajectory, at least the decline in pain from severe to moderate to mild, is different over the course of a week for various types of operations. And I think we observe this in our clinical practice, although we don't always design our regional anesthetic techniques based on these data. If we take it a little bit further, this is an interesting study that was published from Patrick Tye's group at the University of Florida, looking at clinical data from hundreds of patients having various types of surgeries. And what you see are actually 4 naturally occurring trajectories of pain. And this is regardless of type of surgery. And you see here that there are some patients who start out at the beginning postoperatively with very severe pain, and they stay severe for a week. There are some patients who start out with almost no pain after surgery, and they stay relatively pain-free for the whole week. And then you see this this dashed line where patients have a very steep trajectory of pain resolution from moderate to severe down to mild within the course of the first couple of days or half a week. And I think that this is really interesting data. And if we try to factor in this goal of having personalized pain medicine, then we really need to understand the course of pain resolution for various patients and different types of surgeries, and use that to decide what makes the most sense. And so of the technologies that we currently have, as I mentioned, a single injection, if you use an adjuvant or no adjuvant, is really a bit of one size fits all. For some patients, the duration of that single injection dose may be enough. For some patients, it may be too much. And for some patients, it may not be enough. Whereas a continuous nerve block, as we have it right now, really can be tailored to various types of patients. If a patient needs a longer duration of pain management, the infusion can be continued longer. If the patient needs a different dose or a higher rate of infusion for pain relief, the dose can be adjusted. If a patient does not have very much pain after surgery, then a patient with a continuous nerve block catheter can stop the infusion or decrease the infusion to determine whether or not the pain is severe enough or perhaps mild enough to end the infusion early. And so that tailored approach is feasible with a continuous peripheral nerve block. And so for right now, I would consider the use of continuous peripheral nerve blocks the gold standard for extending duration of analgesia for regional techniques, and primarily because it's titratable. It's something that can be adjusted based on the patient's response and trajectory of surgery. And this is something that single injection blocks really do not offer currently. If you look at just the use of opioids, we know that extending duration of local anesthetic through the use of continuous catheters is very effective. And we see for various types of surgeries in this meta-analysis that's now fairly old, that continuous nerve blocks are very well established in terms of efficacy versus systemic analgesia alone. And we also know that today's pain management for patients having surgery is not the same as it used to be. Local anesthetic administration is really only one part of multimodal pain management. This should also include non-pharmacologic measures. It should also include systemic non-opioid analgesics. And then local anesthesia, which is the bottom row, can be administered any number of different ways. And so when we talk about peripheral nerve blocks and continuous peripheral nerve blocks, we're really only talking about one part of multimodal pain management. So what are some practical considerations when you're trying to decide what do you offer your patients? So first, I think that if you're going to consider using continuous nerve block techniques, then you really should use ultrasound. Ultrasound now has really revolutionized the practice of regional anesthesia, and being able to see the target nerves or plexus, I think, has really changed the way that we not only practice, but also teach and reliably perform any type of peripheral nerve block technique. We know from multiple randomized clinical studies that we performed when I was at UC San Diego that the use of ultrasound for continuous catheter placement is much more effective in terms of speed and efficiency than using blind techniques. The idea of using continuous peripheral nerve blocks really decreases the outliers, and all the outliers that you can see on the right side of each graph are shown in purple. On average, shown in the middle, you can see that the times for placement are reliably shorter, shown in blue, when ultrasound is used. But the outliers really are the ones that people remember. And so using ultrasound really can speed up your practice and give you reliable techniques that can be reproduced amongst multiple members of an anesthesiology practice. When we looked at simulation studies in terms of determining how long it takes us to really teach someone how to do these types of advanced techniques, I think it's important that simulation be part of your training. So if you're just learning how to do continuous catheter placement and you already perform single injection nerve blocks, then I think you're really not starting from scratch, so to speak. We know that if you just do lectures and scanning, as you can see from the bottom left figure, if you just do lectures and scanning, if you retest, you see that there's really not much difference in your performance from the minute you walk in until after that type of a workshop. And unfortunately, these are the types of workshops that we tend to offer at most CME events, scanning on a model and then pure didactics. If you put yourself into an immersive situation where you have iterative practice and you have real-time simulation with a coach who can actually give you some pointers on how to improve your practice, then you see that that actually jumps up your global rating scale in terms of scoring, really to a much more a higher proficiency level, which is, I think, easily accomplished within the course of one day, which I think is fairly profound. So if you are going to learn how to do these types of techniques, I would take some time away so that way you can put yourself into a simulation type of program like this, where you can get some iterative practice and some coaching from experts who know how to show you how best to perform these techniques in your clinical practice. Catheters themselves vary, and so there are multiple off orifice, single orifice. We have stimulating, non-stimulating. We also have more traditional epidural types of catheters, which may be flexible or they may be more stiff. And then more recently, we've had the emergence of these over-the-needle catheters, which are very much like peripheral intravenous cannula, which are in opposition to the traditional through-the-needle technique, which is more commonplace for epidural types of catheters. What we know is that there are some advantages or disadvantages of using certain types of catheter equipment based on the technique. And so when we perform short axis in-plane techniques in which we look at the target nerve in cross-section, and then we introduce the needle perpendicular to the nerve, which allows us the advantage of in-plane guidance, so you can see the needle and the needle tip. The challenge with catheter placement is that that tends to insert the catheter in a direction that's perpendicular to the line of the nerve. And so using a softer or more flexible catheter may be more advantageous with that type of a technique. You can see here that in this particular cadaver study, looking at adductor canal tip migration after range of motion exercises, that those flexible catheters tend to have very little movement around even after range of motion compared to where they're initially placed while a more rigid catheter that's not tunneled tends to have a much wider range of movement and tends to move further away from the target. This is also true for over-the-needle catheters, because over-the-needle catheters tend to be stiffer than through-the-needle flexible epidural catheters. And in this particular cadaver study that we performed, also using range of motion, but this time in the popliteal sciatic region, we found that the catheter over needle equipment actually dislocated almost 1 in 4 times, which meant that the tip was actually away from the target nerve after range of motion, compared to catheters that were placed through the needle. So a flexible type of epidural catheter inserted through the needle had a 0 out of 15 chance of being dislocated, which was statistically significant. The other important aspect to making sure that your catheters work is making sure that they don't fall out until you're ready. So in certain situations, it may be worth tunneling. We do strongly consider using and recommend using an anchoring device, so that way the catheter is less likely to fall out before you're ready. We also recommend using liquid adhesive to try to decrease leakage, as well as multiple occlusive dressings in order to make sure that the catheter is secure, especially if patients are going home. And you can see what this looks like from the outside. And most of our patients who go home with peripheral nerve catheters will remove them themselves. And so, which is why we don't recommend using sutures, so that way patients can easily remove the clear dressings and then pull out their own catheters and dispose of everything at home. So in summary, we discussed the availability of adjuvants for extending single injection peripheral nerve blocks. We also talked about the use of continuous peripheral nerve blocks in the current state of the science, as far as titratability, duration, as well as many practical considerations for making continuous peripheral nerve blocks work in your practice. This area of personalized pain medicine after surgery continues to evolve. And so as new techniques and technologies emerge, as well as new ways to risk profile patients to better understand the trajectories of pain, I expect that this area of clinical innovation will continue to change. And so hopefully we'll have more evidence to tailor our personalized pain management in the future. Thank you very much again for joining.